So it's been remarkable achievements for Hodgkin lymphoma over the last 4 or 5 decades. The cure rate has improved from almost 30% in the 60s to now we expect to cure about 80% or so of patients with Hodgkin lymphoma. If you look at the survival of patients who are cured of disease, unfortunately, is not as good as the cure rate. What this suggests to you that the very curative treatment have toxicity, including early and late toxicity that impact on patient survival, including second malignancies and cardiac disorders. So although we have made a major progress in the cure rate, we really need to continue to find not only more effective treatment, but also safer treatment regimens for this younger patient population. But having said that, despite this progress, if you look at the current treatment regimens being used for patients with Hodgkin lymphoma, it really didn't change much over the last 3 decades. ABVD was introduced in the 70s, and we still use ABVD today. And in the relapse setting or refractory setting, most of us use either platinum-based regimens or gemcitabine-based regimens. Again, these regimens have been introduced in the 80s and 90s, so we've been using them for almost 20 years or so. Nothing have changed much, except we played with the number of cycles and reduced them in some instances, added radiation, changed the radiation field, and so forth. Now, if you look at the results of salvage regimens, there's no randomized trial comparing different salvage regimens in pre-transplant setting. But face value, they all look about the same. Most of us use ICE regimen in pre-transplant setting, but some of us also use gemcitabine like IGEV or GVD. This is a comparative, again, results of PR and CR's overall response to these different regimens in an unrandomized way. And this is just an example of this salvage regimen. This is the GVD regimen that was reported by Nancy Bartlett. And this GVD regimen was used in 2 instances, one in pre-transplant and 2 in post-transplant setting. In pre-transplant setting here, you can see that the progression-free survival, what you expect with the transplant consolidation, about 50% of the patients would do fine over the years. In the post-transplant setting, keep in mind that this is a 3-drug regimen. The median progression-free survival is about 6 months. And keep this in mind because we want to compare it with the other regimens that are less toxic in this setting in the post-transplant. And for patients who are not cured with transplant, especially those who relapse within a year from a transplant, they have dismal prognosis. Again, keep in mind that this median age of these patients is about 30, 32 years. So when a patient dies in the mid-30s, its impact on human life is tremendous. This is a compiled data from 6 centers, including ours in Stanford, reported by Sandy Honig and two Luganos ago, showing that if you relapse from autologous transplant, the median survival is about 2.4 years. All comers, but if you relapse within 1 year of autologous transplant, the median survival becomes about 1.5 years. So this demonstrated that for patients, especially who fail autologous or relapse after autologous transplant, this is an unmet medical need, and it was area for new drug development. And luckily, there's been several new agents being tested in this area for potential FDA approval. One of them has been approved, was mentioned before, is the SGN-35 or brentuximab vedotin. But this is summary data from several trials that have been tested in patients who relapse mainly post-transplant. And showing you that the SGN-35 or brentuximab vedotin had a higher response rate. The early naked anti-CD30 antibodies did not show any meaningful clinical responses. But the other class of agent that also showed some interesting data is the HDAC inhibitors, and also the lenalidomide and mTOR inhibitor showed some promising data, but none of them has been approved for this indication. This is, again, summary data for single-agent activity mainly in post-transplant setting. And here I put the GVD regimen that I just showed you from Nancy Bartlett data in the post-transplant setting. This is a 3-drug regimen. Yes, you can have a good response rate, about 75 response rate. This is a CR rate, so the CR rate is still low. But if you look at the SGN-35, it's almost the same outcome with a higher CR rate compared to 3-drug regimen and less toxicity. So this is the drug. It's the same naked antibody that was previously tested. It was coded as SGN30. It's a chimeric antibody. It uses the backbone of AC10 antibody. And when you conjugate it through a cleavable linker, on the average, each antibody is conjugated to 4 toxins, which is MMAE. It's a microtubulin disruptive agent. When the antibody-drug conjugate binds to CD30, it's internalized, it releases a toxin, poisons the microtubule, initially leads to G2M cell cycle arrest, and then it's followed by apoptosis. The phase 1 data is now published about a year ago in the New England Journal, used in escalating doses of SGN35. The initial phase 1 used 1 dose every 3 weeks, and there was a second phase 1 trial that used a weekly doses 3 weeks out of 4 cycles. The data from this phase 1 trial showed, again, remarkable responses for an agent, single agent that tested in a phase 1 setting. It was obvious that this is going to become a drug from this waterfall plot, showing that the majority of patients, regardless of the dose level, have responded, but the overall response rate, especially in those who were treated in the higher dose level, was about 50%. And some of these responses were really remarkable. So we're not talking about small lymph nodes that disappeared. Some of them had bulky disease in a post-transplant setting and had a complete remission. This is a patient of mine who had a tremendous amount of disease, almost the entire left chest area and then down to the abdomen was faced by a tumor, and after 4 cycles achieved almost complete remission in this case. The reason why I'm showing this is not just to show that the drug works in a bulky disease setting, but if you remember the pathology of Hodgkin lymphoma, the tumor cells are infrequent. The bulk of the disease is infiltrating reactive inflammatory cells, B cells and T cells and monocyte and dendritic cells. And this shows you, and in my opinion, this is the first scientific evidence that the red stomach cells, in fact, attract these infiltration. So if you eliminate a small number of cancer cells with this targeted agent, this heavy infiltrate disappear, leading to a complete remission. With this, then 2 phase 2 trials were conducted, one in Hodgkin lymphoma, one in anaplastic large cell lymphoma, and I'll show you data for Hodgkin lymphoma. It adapted the every 3-week schedule and basically showed it adopted the MTD dose, which was 1.8 milligram per kilogram every 3 weeks. 102 patients were treated in this phase 2 trial. 71% of the patients had a primary refractory disease, and by default, all patients were required to have prior autologous stem cell transplantation. The overall response rate was 75%, and a complete response rate was 34%. The median duration of response was 6.7 months. And this is a waterfall plot from the phase 2 data. Almost everyone had reduction in the tumor measurements except 2 patients. As I said, there was 34% achieved complete remission, and the complete remission was durable. At the time of preparing this slide, which was at last Lugano, the median duration of complete remission was about almost 2 years. It was 20.5 months. This data is being updated now, exceeded 2 years actually, which will be updated at the EHA conference in Amsterdam. And this is the progression-free survival based on the response. Patients who achieve complete response in the yellow graph here, you can see it do very well. Those who achieve partial or stable disease, the median duration of response, as you may expect, is shorter. Because some of these patients achieved complete remission, some of them were offered allogeneic transplant, and some were either not offered transplant, or didn't have a donor, or refused transplant. And this is, again, a small number of patients who had allotransplant, only 5 patients. And these are who achieved CR and did not go into transplant, but shows you that the median progression-free survival in these 2 groups were about the same. This is actually the most frequently asked question these days. If a patient achieved a complete remission, should they go to transplant or not? And no one really knows the answer what to do with these patients. My default, if they have a matched donor, allogeneic transplant may not be a bad option. If not, my preference is to keep observing the patient. These are the side effects from this agent. These are the most frequent side effects observed in more than 20% of the patients, irrespective of relationship. As you can see, grade 4 toxicities are infrequent. Only 6% of the patient had neutropenia, and even grade 3 toxicities were infrequent. Most of the toxic effects were grade 1 and 2. And as mentioned before, the most frequent side effect is neurotoxicity, which is cumulative. It starts after 3 to 4 doses, and the frequency and the intensity of the neurotoxicity increases with increased dosing. But the good news is that it is resolvable in about 80% of the patients, and it disappears completely in about 50% of the patients with either dose reduction or discontinuation of the agent. So what do we do with this? As you know, that the phase 2 data led to the FDA approval for patients with relapsed Hodgkin lymphoma post-transplant or failed at least 2 regimens. So even in a pre-transplant setting, they can qualify for this agent. But I think the impact will come from combination strategies. And then the question is, should we combine it with ABVD in frontline setting? And if so, would then a randomized trial, if it becomes positive, change the natural history of the disease? I think we'll have to wait and see next few years when this randomized trial is conducted and completed. But in preparation for this randomized trial, we did a phase 1 combination trial with frontline ABVD initially, and then we dropped the bleomycin and combined it with only AVD. So patients received the standard dose and schedule of ABVD or AVD once every 2 weeks, and with every dose of ABVD or AVD, they get 1 dose of SGN-35. Keep in mind that the approved indication for single-agent SGN-35 is 1 dose every 3 weeks. Here we give it every 2 weeks and in combination with chemotherapy. So we had to do a phase 1 trial from start. There were 2 cohorts in the trial. The one was a full ABVD, started with the 0.6 mg per kilogram up to 1.2 milligram per kilogram. And once we settled on this dose, then we moved to the AVD with no bleomycin and treated a total of 26 patients with the 1.2 milligram per kilogram plus AVD. The data was presented last ASH, and I'll just give you the highlights from this presentation. In short, the ABVD plus brentuximab showed a higher than expected lung toxicities. It's exactly like what you see with bleomycin. With bleomycin, with ABVD, the expected bleomycin toxicity in the average about 10%. Here we saw about 40% lung toxicities. But when we dropped the bleomycin from this regimen, it became 0% response rate. And that's the regimen that will be adopted for the randomized trial. It will be AVD plus brentuximab versus standard ABVD. The other important information from this trial that the response rate was remarkable. At the time of presentation, some patients were still on trial, so we had only 15 evaluable patients at that time, and all 15 patients achieved complete remission. What also was remarkable also when we did interim PET analysis, and if you remember that the interim PET analysis for patients receiving frontline ABVD, if you're PET positive, the outcome is bad. Almost all patients will progress. If the PET is negative, you do well. So here we're looking at interim PET, and then almost everyone had interim PET negative status except 1 patient. What will come out of this, we don't know what's the prognostic impact of PET negative status in brentuximab-based regimen, but I'm sure it's going to be good. Finally, very briefly, touch on a class of agents, the HDAC inhibitors. There are several HDAC inhibitors, and Steve mentioned a couple of them approved for cutaneous T-cell lymphomas. We've done a couple of trials with these agents. The first trial that we did is with the oral HDAC inhibitor, which is a class 1 agent at MGCD0103. Now it's called mosetinostat. Data was just recently published in the Lancet Oncology, and showing that, again, in heavily pretreated patients, this is a patient who had 10 prior treatment regimens, an oral agent induces a very good response rate in this setting. If you look at the waterfall plot, about 60% of the patient had a reduction in the tumor measurements, but the overall response rate, PR plus CR, was only about 25%, so it did not make it into further development as single agent for potential approval like brentuximab. And the second agent, which is a panobinostat, it's a PANDAC inhibitor. This is an international trial that was pivotal trial, also seeking potential FDA approval. Same pattern. You see about 60% or so had reduction in their tumor measurements, but the overall response rate was less than 25%, and this did not lead to an indication for approval either. And finally, the PI3 kinase and pathway inhibitors also making some news in Hodgkin lymphoma. And this is a summary slide looking at different agents. The only one that has been tested in this pathway is everolimus, showing about 53% response rate in a single institution. And then a multi-center trial then tried to duplicate this data, was presented last ASH, showing about 30% response rate. There is no data about the other inhibitors, although there's clinical trials targeting AKT with the MK2206 in Hodgkin lymphoma, and one with the CAL101 that is ongoing right now, also with Hodgkin lymphoma. So in conclusion, I think it's an exciting time for patients with Hodgkin lymphoma. We went from nothing to offer them for almost 4 decades to plenty of drugs that are now being tested. The last drug that was approved by the FDA for Hodgkin lymphoma was in 1977, and we have now at least one drug approved for this indication. What you'll see in the next few years, several combination strategies in pre-transplant setting and in a frontline setting, and I just showed you what would the future randomized trial look like, would be AVD plus brentuximab versus ABVD, and I hope that all of you would participate in this trial. Thank you.